If the lung compliance were to increase, would it be such a bad thing? One would have thought, no, it's good. The lungs are more and more distensible. Compliance is a measure of distensibility. But imagine, along with increased distensibility, if the lungs have lost their elastic recoil, which is required during expiration. In addition to that, there is narrowing of the airways and air is unable to come out during expiration. What will happen? The lungs will distend more and more, but they are unable to expel the air out during expiration. So there will be great distension, over distension of the lungs associated with damage to the lung parenchyma and many more consequences. Do you know which disease we are talking about? We are talking about the emphysema in the lung. So let's talk in this video about the pulmonary emphysema. In the end, I will also tell you how to remember all the features of emphysema with 6 E's associated with the emphysema. The E's, 6 E's, easily you can remember the features of emphysema with those 6 E's. But first things first, let's define emphysema and let's also see the pathophysiology. Generally speaking, emphysema is over-distension of any tissue with air or gas. So technically speaking, it could happen in any tissue. For example, there is something called as surgical emphysema, when the air accumulates in the subcutaneous tissue. But we are going to limit ourselves to the pulmonary emphysema. So let's see what happens in the emphysema of the lung. It's a complex process. First things first, it's a complex process. There is destruction of the lungs, destruction in the lungs as a result of chronic obstruction of the airways. So the point that you should remember is that it starts with obstructive disease of the airways. There is chronic obstruction in the airways, and then it progresses to also damage the alveoli and lung parenchyma. So something happens in the airways first as a pathophysiology, then it proceeds to damage the alveoli and alveolar walls. Then it also damages the pulmonary capillaries located in the alveolar walls, and eventually, since the circulation is involved, it will also burden the right side of the heart, because right side is supposed to pump the blood into the pulmonary capillaries. So remember, sequentially the things happen like this: airways first to be affected, then the alveoli, and then the pulmonary capillaries or the circulation affected eventually. All right. So overstretching, over distension of the lung parenchyma, destruction of the alveolar walls. Now that's quite logical to understand. If the alveoli are overstretched, eventually the walls will be damaged and destroyed, and also destruction of the pulmonary capillaries. Let's start with the etiopathogenesis. What is the etiology? And then we'll also see the pathophysiology and pulmonary function tests associated with it. Etiology. Most commonly, it is associated with chronic smoking. Yes, that's the most common reason or etiology that eventually results in the emphysema. Chronic infection. Look, if there is inhalation of the smoke or any other irritant, it will start damaging the airways. It will start causing damage in the airways first. So irritation of the bronchi and bronchioles because of the smoke, because of that irritant. Normal defense mechanisms of the airways are deranged. There are normally cilia which are going to cause movement, and they will throw out the smoke, they will protect the lung parenchyma, but that gets deranged. In addition to that, there is nicotine that is inhaled in the chronic smoking. So there is, because of the nicotine, there is partial paralysis of the cilia that line the respiratory epithelium. You can see here the cilia which are lining the respiratory epithelium, and normally they act as a defense mechanism. They move and they throw away the particles or the smoke, and they are not allowed to reach the alveoli. But if the cilia are paralyzed, then the defense is breached. So yeah, and in addition to actually the smoke or other irritants, it's the mucus the mucus that needs to be cleared of the airways has to be thrown out of the airways. But if the cilia are paralyzed, mucus cannot be easily moved. It cannot be easily moved out of the airways. That will result in the mucus plugging of the airways. The mucus will become hard, it will accumulate, become hard, and it will form the mucus plugs. Now that will start obstructing the airways even further. So there is also stimulation of excess mucus production. With chronic irritation, excess mucus is getting produced. So look at this, excess mucus is being produced, but the ability to throw that mucus out by the cilia and other mechanisms, those mechanisms are not working properly. So obviously this is going to cause accumulation of the mucus plugs, and it will further exacerbate the condition. First point that we have seen is mucus plugging of the airways. Then inhibition of the alveolar macrophages. Alveolar macrophages are another part of defense mechanisms in the lung. If they are inhibited, it weakens the defense against the infection. And therefore, the airways, the alveoli, the lung parenchyma, all of these are now prone to infection. So what happens is, there is infection, there is excess mucus production, and edematous airways. You know, if there is inflammation of the airways because of the irritation, it will lead to thickening of the airway wall, edematous airways. Now this will result in chronic obstruction. So something that starts with COPD, something that starts as COPD or chronic bronchitis, will then progress to emphysema. And this chronic obstruction is particularly of the smaller airways. That's quite logical to understand. Mucus plugs are to be cleared. It will be more difficult to clear those mucus plugs from the smaller airways. So they will get obstructed early and easily. All right. Now what happens next is obstruction of the airways. So expiration becomes more difficult. I want you to keep this in mind, that whenever there is airway narrowing, obstruction or narrowing of the airways, inspiration is easy, relatively easy, but expiration is much more difficult. Why is that? It's because with inspiration, the lungs are distending and there is negative intrathoracic pressure, so it pulls open the airways, and therefore inspiration is easier. But then with expiration, there is positive pressure plus the recoil of the lungs that compresses the airways. Airways are already narrowed, they are already obstructed, and further narrowing with the expiration. So expiration becomes much more difficult compared to inspiration in the conditions of COPD. What happens in these conditions is that there is early closure of airways. Early closure of airways. Early means earlier than expected, earlier than desired. So early closure of airways during expiration, because of which the extra air gets trapped within the alveoli. And this goes on happening and happening. Slowly, the extra air is getting trapped in the alveoli. Alveoli are getting more and more stretched and distended. Eventually, they are so much distended that their walls will be destroyed. So that's what happens in the emphysema. It started as the airway disease, but it led to damage of the alveoli and also the pulmonary capillaries. So overstretching of the alveoli, destruction of the alveolar walls. We saw first what happens in the airways. Now we see what's happening in the alveoli, destruction of the alveolar walls due to excessive stretching. And then capillaries in the alveolar walls are also destroyed. 50 to 80% of the alveolar walls are destroyed. That's too much. That's too much. Almost half the lung will become dysfunctional. So for the sake of remembering, remember it like this in 3 steps. First damage or first problem is with the airways. Then second, it progresses to the alveolar damage. And then even the pulmonary capillaries are destroyed. That's the sequential manner in which you can remember these, the pathophysiology of emphysema. All right, so overstretching. Now let's first see the pathophysiology in little more detail. There is increased airway resistance work. Just as I said, it starts with chronic bronchitis and therefore it increases the airway resistance. Airways are edematous, that's E for edema, edematous airways, and they are inflamed, they are narrowed, early closure of the airways happens. So total work of breathing is also increased, and it's because of the increase in the airway resistance work. Expiration is more difficult than inspiration. Well, we said that just now, that the reasons. Inspiration, there is negative intrathoracic pressure, so it can open up the airways to some extent. But with expiration, positive pressure plus the recoil of the lungs, it will compress the airways which are already narrowed. All right. Now, this point needs a great understanding. EPP is shifted in the lower airways. This requires some kind of physiology understanding. Equal pressure point. Look, let's say you have taken a deep inspiration, forceful inspiration, and then you start expiring. Intra-alveolar pressure is, let's say, plus 20 centimeters of water. Atmospheric pressure is 0 at the outlet. So that means there is going to be a dissipation of pressure head. Pressure will drop and drop and drop as the air flows through the airways during expiration. So plus 20, plus 18, plus 16, plus 14, plus 10, plus 8, plus 6. At some point, at some stage during expiration, the pressure inside the airway and pressure just outside, that is in the interstitium, those two pressures will become equal, and therefore that point is called as equal pressure point. Now this point, normally in healthy individuals, it is in the upper 7 generations which are cartilaginous. See, if the equal pressure point is reached during expiration, it means what? Beyond that point upward, the pressure inside the airway will be less than the pressure just outside. Do you get the point? If plus 6 inside and plus 6 outside, then beyond that point, plus 5, plus 4, plus 3, but outside pressure is plus 6 only. So now the airways are prone to compression. Airways are liable for compression. But since that equal pressure point occurs in the cartilaginous airways, that compression is not so much great because cartilage will provide a good tethering effect. This is what happens in the normal healthy individuals. Now with that perspective, try to understand what happens in the chronic bronchitis and emphysema. That the equal pressure point shifts downward towards the lower airways. Lower airways means non-cartilaginous airways. So what happens? Two things. As you start the expiration, equal pressure point is reached early because now the EPP, equal pressure point, has shifted downward. So it reaches early in your expiration. That means there will be early closure of airways after that point. All right. And second thing, therefore, is that further expiration will become more and more laborious because EPP has gone into the non-cartilaginous airways. Therefore, they are prone to further and further compression, more compression. So remember, because EPP has shifted downward as a result of disease process, there is early closure of airways, and therefore expiration is more and more laborious. See the consequence of that. Suppose you inhale 500 ml of air. This is just for the sake of understanding. We are taking some arbitrary figures. You've taken in inspiring 500 ml. Now normally you are expected to exhale out the same amount, 500 ml with expiration, but that does not happen now. Because of the early closure of airways, you inspired 500 ml, inspiration was easy, but during expiration, only 490 ml could come out. 10 extra ml were trapped in the alveoli. Why? Because of the early closure of the airways. So extra 10 ml got trapped in the alveoli beyond that beyond those closed airways. And in this manner, 5 ml, 10 ml, 5 ml, 10 ml will go on getting added to the alveoli, resulting in overdistension, overstretching of the alveoli. Eventually that overdistension will cause damage to the alveolar walls. So this is what happens with the early closure of airways. So far I told you edematous airways, that's equal pressure point, EPP shifts downward toward the lower airways, non-cartilaginous airways. So EPP shifted, that's another E. Third E was early closure of airways. That makes expiration more difficult, that's another E. This is how you can remember the features of emphysema. So early closure of airways. Let's see now what happens as a consequence of that. During the expiration, early closure, so residual volume will increase. Obviously air is getting more and more is remaining in the alveoli, so residual volume will increase, FRC will increase, and TLC will also obviously increase. Over a period of time, the lungs are getting more and more stretched and distended with air. It will result in barrel shaped chest. As you can imagine, this is the normal shape of the chest wall. Now with over distension of the chest of the lungs, the chest wall will become barrel shaped. So remember, in emphysema there is barrel shaped chest. Now at the FRC, look at this feature. At functional residual capacity, the lung volume may be about 2.5 to 3 liters in a normal healthy subject. At the end of quiet expiration, what remains in the lungs? Functional residual capacity, FRC. How much that volume is? Normally it's about 3 liters at the most in a healthy subject. But in emphysematous lung, it is as high as 7 to 8 liters. 7 to 8 liters. At the end of quiet expiration, lungs are really over distended with air. All right. Now coming to the another tricky part to understand. That's compliance. Compliance increases in the emphysema. Look, what happens is that alveolar walls are getting damaged. If the alveolar walls are getting damaged and alveoli coalesce to form larger cavities, what happens as a result of this is that when the wall was there in the normal healthy subject, in order to distend that wall, some effort would be, or some work would be required to distend that wall, alveolar wall. Now since the alveolar wall is destroyed, therefore now it's relatively easier to distend this one cavity which has been formed after destruction of the alveolar wall. So the consequence is that the lung compliance increases. We saw that at the start of the video, lung compliance increases. So it should have been good actually. No, it becomes a curse rather than a boon. Why? Let's see. Normally the lung compliance is about 200 ml per centimeter of water. For every 1 centimeter of water pressure change, the lung distension is by 200 ml, 250 ml, etc. But here now it can increase up to 900 ml per centimeter of water. That means more than almost or 3 times the normal. So that's what happens with the emphysema. The lung compliance increases, and it can be shown by the graph. This is the graphic depiction of increase in the lung compliance. You can see the curve for the normal. First of all, what is compliance? It's a pressure volume relationship. So you can see on the horizontal axis there is transpulmonary pressure. As the transpulmonary pressure widens, what happens to the lung volume? That is shown on the vertical axis. So this is for the normal. And now you can see that the curve has shifted leftward and upward in the case of pulmonary emphysema. This is the curve for emphysematous lungs. And what is the curve telling us? A steeply rising curve, meaning that for a small change of transpulmonary pressure on the horizontal axis, there is great rise in the lung volume. For a small change in pressure, great rise in the volume, that means the compliance has increased. And just to make you compare, this curve is of pulmonary fibrosis. You know, in pulmonary fibrosis, the compliance decreases, the stretchability decreases. So you see the curve has become flat. It has gone rightward and downward because the compliance decreases in pulmonary fibrosis. All right. But nevertheless, look at emphysematous curve. Very steeply rising. That means volume on the vertical axis is rising very steeply for a very small change on the horizontal axis, for change in the transpulmonary pressure. So this is the change that happens in the emphysema. And even though compliance, that is distensibility, is increasing, but as I mentioned, elastic recoil decreases. Note this point again, another E, elastic recoil decreases. So you can imagine now that the lungs are distending because compliance has increased, but elastic recoil has reduced. So most of the problem is during expiration. There is no elastic recoil. That means the lungs will only take up air more and more. Lungs will go on distending and distending and distending. Air is not coming out easily because there is loss of elastic recoil. All right, another E. FEV1 decreases. You know that time vital capacity decreased in the obstruction of the airways. So FEV1 decreases, that was expected. Loss of the alveolar walls, overstretching, finally the walls are damaged. This decreases the diffusing capacity of the lungs. Obviously, if the alveolar walls are getting damaged, destroyed, plus the blood vessels are also getting destroyed, that means the diffusing capacity of the respiratory membrane will decrease. So decreased oxygen diffusing in the blood and increase in the carbon dioxide in the body. Carbon dioxide also diffusing less from the alveolus into the or rather from the blood into the alveolus. So carbon dioxide build up. That's another story of emphysema, built up of carbon dioxide and hypoxia. Increased arterial PCO2 up to 60 mm of Hg. Normal PO2 is in the range of 45 to 46 mm of Hg. Now it has increased up to 60 mm of Hg. And you know CO2 means H plus. So CO2 rise means H plus rise. This will result in acidosis. Now to compensate for that, the plasma bicarbonate will also increase to compensate for the acidosis. So there is respiratory acidosis, and to compensate for that, the increased bicarbonate. Now this is another important point that I want to highlight. The obstructive process is worse in some part of the lung compared to the other. So what happens? I want to highlight this, and please have a great understanding of this particular thing. Some regions may be well ventilated, but some regions are poorly ventilated. So what happens is, there may be very low ventilation to perfusion ratio in some regions. In some regions the ventilation is low because alveoli have been damaged, destroyed. So ventilation to perfusion ratio is also low, numerator is less. This is called as physiologic shunt. Means what? Less ventilation but relatively more blood perfusion. So blood is just shunted past the alveoli without picking up oxygen. So it is called as physiologic shunt. And in some other areas, there is very high V to Q ratio. In some other regions, ventilation is there, but there is no enough blood perfusion to match it. Which means what? Which means that ventilation is wasted because there is no blood flow to pick up the oxygen. So wasted ventilation. But the point that I am trying to highlight here is that in the same lung, some regions will show physiologic shunt, some regions will show physiologic dead space, but the net result is wasted ventilation. So that's a important pathophysiological feature seen in emphysema, the wasted ventilation, as both effects are seen in the same lung. Physiologic dead space is almost doubled. All right, now let's see the third part. We saw what happens in the airways as chronic bronchitis. Then we saw what happens to the alveoli, alveolar walls. Now the third point is pulmonary capillaries in those alveolar walls. Destruction of the alveolar walls, so loss of pulmonary capillaries. Now low number of capillaries now available, so blood has less capillaries available now to flow through, and therefore it results in increased pulmonary vascular resistance. Now the blood has less channels to flow through, and therefore increase in the vascular resistance. Therefore it results in pulmonary hypertension. There are two reasons that emphysema leads to pulmonary hypertension. One is many pulmonary capillaries have been destroyed because they were in the alveolar walls, and therefore with destruction of alveolar walls, the capillaries destroyed, less capillaries available for the blood to flow through the lungs, and therefore there is pulmonary hypertension. The other reason is that pulmonary emphysema patients, they are hypoxic, and there is a hypoxic stimulation for the production of RBCs. You know that erythropoiesis is stimulated by hypoxia. So these patients will have secondary polycythemia. Secondary polycythemia. That means increased RBC count. And if the RBC count increases too much, there will be increased viscosity of the blood. The blood flow through the lungs will be now very slow because there is a viscous drag over the blood because of the high number of RBCs. So therefore, pulmonary hypertension is further exaggerated. All right. And since the pulmonary hypertension is there is increased workload on the right side of the heart. Obviously, right side is pumping the blood into the pulmonary circulation. So with pulmonary hypertension, pulmonary vascular resistance has increased. Right side will have a greater workload, and therefore eventually there will be right-sided heart failure. And as I mentioned, secondary polycythemia due to the prolonged hypoxia, hypoxic stimulation for erythropoietin and erythropoiesis, there will be increased RBC count, and therefore sludging of blood in the pulmonary capillaries. The blood flow will be very sluggish, and that will also increase the burden on the right side of the heart. So right-sided failure is also another consequence of all this disease process. Okay, emphysematous patients take short breaths. Look, they could inspire the air because lung compliance has increased. So high amount is going in, but it cannot come out because of the early closure of the airways. So they have to take multiple short breaths to expel that air out, which was inspired in during a single breath. And because of such kind of a laborious breathing, their skin appears pink temporarily, and therefore they are called as pink puffers. So please remember, those who are reading clinical subjects, emphysematous patients are called as pink puffers, and chronic bronchitis patients are called as blue bloaters. Okay, so this is the pathophysiology of emphysema. Finally, let's see those 6 E's which will make you remember the entire disease process. Edematous airways. Yes, there is inflammation of the airways, edema of the airways. Their airways are narrowed. Excess mucus. Mucus already, excess production of mucus, plus the mucus clearing mechanisms are damaged so mucus cannot be cleared, mucus plugs are formed, EPP shifts downward, we saw that, so therefore it results in early closure of the airways, so expiration is difficult and elastic recoil is decreased. So 6 E's, and you remember the entire pathophysiology of emphysema. That's in short the pathophysiology, disease progression seen in the emphysema, and just remember these 6 E's, you will remember the entire process.